We are live now. Hello, please check.
हॅलो बोल ना. हॅलो
तुमच्याकडे फोन मध्ये का?
नाही मग आता ते
इथून झालेलं आहे ना.
आहे ना तुम्हाला हॉल
11-12 सेकंड झालेत. हॅलो, येतं आता? बरं. हॅलो, चेक चेक. हॅलो. ओके, डन ना. व्हिज्युअलचं काय बघायचं तुम्हाला?
ते हॉल मध्ये
व्हिज्युअल क्लिअर करायचे? व्हिज्युअल क्लिअर करायचं आहे का?
कोणत्या हॉल मध्ये अभय हॉल मध्ये करला था.
आलेलं
आवाज पण येत आहे ना?
प्रॉपर आहे. एकदा हेडफोन लावून चेक करता का प्लीज? आणले नाहीत का? असू द्या मग. हा, क्या कैमरे का लेवल बढ़ाओ. माइक का हेलो चेक चेक. हेलो हेलो, इतना करेगा. हेलो 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 हेलो. हाँ मैं खुद ही बढ़ाया वो. ये देख माइक कितना दूर है अभी. ये है ना चैनल 3 और हाँ ऑक्सफोर्ड हो.
कोणता ओळख आहे?
ये वाला हाँ वाला
कोणाचा ओळख आहे?
वाढव ना हा वाढव. हेलो 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 चेक. हेलो ठीक है राहुल. हेलो बड़ा. हेलो चेक. हेलो 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 चेक 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 चेक. हेलो चेक. ये तो क्लोज होगा ना. इतना तो रहेगा कम से कम. सॉरी. हेलो चेक. ठीक है राहुल. इतने क्लोज होगा फटेगा तो नहीं. फिर भी अगर कोई ऐसी बात करे तो देखना तो दोनों पड़ेगा ना. ठीक है. होगा ना. चेक. हेलो चेक. हेलो चेक 1.
लेट येते थोडा.
हेलो चेक.
लेट येते थोडा.
चेक 1.
हेलो चेक आला नाही ना
फेसबुक मध्ये आहे ना फेसबुक मध्ये पाय ना टाक सोसायटी ऑफ क्रिटिकेअर मेडिकल मेडिसिन
इंडियन
फेसबुक मध्ये
फेसबुक मध्ये
साउंड हे बोल रहे
बोल रे हेलो चेक हे चेक वन
थोड़ा डिले तो होते हैं
हेलो चेक चेक वन हेलो हेलो चेक वन हे चेक हेलो हेलो चेक वन टू हेलो चेक हेलो चेक
5 सेकंड बोल डिले
भाई और बहनों,
लाइव स्टार्ट हुआ है।
रेकॉर्डिंग स्टार्ट व्हायची आहे ना? हेलो भाइयों, क्या चालू है आपका? का?
अरे तसं ते येणार आहे का? आपण सगळं रेडी करून ठेवलं.
हेलो हेलो चेक वन. हेलो चेक चेक चेक. हेलो चेक 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 वन टू. माइक टेस्टिंग टेस्टिंग. हेलो हेलो.
check one. Hello, hello. Hello, check one. Hello.
Hello? Hello, 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 hello.
Yeah, it's working now.
You'll be coming to Brussels?
I have to be in Amsterdam for several PhD ceremonies, so I prefer this time not to go. But you will be there. Big meeting always.
So, a very good afternoon to all the viewers who will be joining us on Facebook and YouTube. My name is Dr. Tahir Ali Khan, and I welcome you all for this Criticare live session. Today, we will be discussing on some of the most pertinent topics in critical care, and we will be having a team of experts, the renowned leaders in the field of critical care, who will be guiding us and sharing their experiences with us. So, we'll start this session with the introduction and welcoming our faculty. First of all, I welcome Dr. Marcus Schulz, sir. He is professor at UMC Amsterdam from Netherlands. Thank you so much, sir, for coming, sir, and welcome.
Pleasure to be here.
And we have Dr. Subhal Dikshit, sir, who is the director at Sanjeevan Hospital and MGM, Pune, and sir is the past president of New Society of Critical Care Medicine. Welcome, sir.
Yeah, good afternoon. Thank you.
We will be shortly be joined by Dr. Subhash Todi, sir, and Dr. Kapil Zirpe, sir. And so let's begin this discussion with our first question to Dr. Marcus Schulz. And he will be talking on phenotypes of ARDS and ventilation strategies, new ventilation strategies in ARDS. Sir, is ARDS a single disease entity, or it's a syndrome with multiple underlying pathophysiologies? Do we have a consensus on the conceptual model of ARDS?
Yeah, I think that's a very good question. As the name already suggests, it's a syndrome, and usually we call something a syndrome in medicine if we don't know really what it is, or whether it's a combination of several things or different disease entities. And I think that's the case, of course, as we all know. The big question behind this is, of course, if there is a concept, do we trust that concept? And we recently performed a Delphi study, which will be published very soon in the Lancet Respiratory Medicine, in which we asked a group of panelists to come to a consensus whether or not it's a construct that we have to believe in, that we can use at the bedside. And I think that the conclusion must be yes, we all believe that there is a construct, that it's a gestalt that's really existing, but there is the question of subphenotyping. And this is something we can discuss a little bit later on, why we would do subphenotyping and how you do subphenotyping.
Dr. Subhal Dikshit, sir, would you kindly like to add something?
No, I agree with what Marcus had said. Definitely, it's a syndrome. You need to identify exactly, and that would really help us to guide how the management of ARDS is really going to take us through.
So the next question, sir, if we have seen with sepsis that subphenotypes have a major role in management, and with some certain phenotypes getting benefit with certain interventions and others don't. So can we apply the same concept of subphenotyping in ARDS also?
I think yes. And it's not only in sepsis that subphenotyping is maybe the way to go. Also other diseases this is now done, like in cancer and in other pulmonary diseases like asthma. And it's very beneficial to have that approach. And we actually have some evidence as well. So there's the group of Caroline Calvi, who showed that if you look at groups of patients, there are a large group of ARDS patients, there are actually one or two or three or more groups that respond differently to treatments that we tend to give at the bedside, like a higher level of PEEP, for instance. The big question is how to apply this knowledge at the bedside, so in your direct patient care. And this is, I think, still a long way to go, because recognition of the subphenotypes is something which is now done retrospectively using data that are not always available. Again, coming back to this Delphi that we recently performed and that will be published soon in the Lancet Respiratory Medicine, if you ask the panelists about what they think about subphenotyping and how useful it is, they say it's very useful in research, but whether it will be useful in education and whether it will be useful for patient care, that is still something we have to decide, and we have to find more data that can confirm that.
Marcus, can you add on to, like, Gattinoni came up with the phenotypes in ARDS, for the first time that time. Do really the management protocols change? That's the question. Does the management really change depending upon the phenotypes? Because now we know that ventilating ARDS really is a set formula. Like initially we used to ventilate for normalization of gases, but that concept has gone. Now we ventilate ensuring the safety of the patient. To have a peak pressures to be kept below 35, a plateau pressure about 28, and there is no consensus exactly what is the best PEEP which should be given.
Yeah.
So does the phenotype change? Does the management really change if you can identify the phenotypes?
Yeah, I think that's a very good question. Actually, I think Luciano Catinoni, when you're talking about the subphenotyping, and I think you refer to what happened in the COVID ARDS patients with the L and the H type, I think he was right and wrong at the same time. I think early in the start of the pandemic, we indeed had two phenotypes because I think that many patients at the beginning of the pandemic were simply intubated because of hypoxemia, but not because their lungs were so extremely stiff, for instance. And those patients were managed later on very well with HFNO instead of invasive ventilation. So one of the subphenotypes simply disappeared over the first couple of months. But you can also turn it around and say, but he was right that there are different phenotypes. And actually it showed that there was another treatment necessary in the one phenotype, which, as I already said, was HFNO in that one group. And in the other group, invasive ventilation, probably with a higher level of PEEP.
Meanwhile, we are honored to have Dr. Subhash Todi sir with us. Dr. Subhash Todi sir is the Director of Critical Care and Emergency Medicine and Head of the Department of Academics and Health Research at AMRI Hospital, Kolkata. And sir is the cornerstone of all the ISCCM guidelines and various books which have been published for that. So welcome, sir, and thank you for joining us.
Thank you.
So, sir, we have interesting discussion we are having, and the thing is that we opt for biology, leaving maths, and after that we are always fascinated about the magical numbers. We are always chasing the magical numbers as to what we can, move forward. How much compliance should we beyond what we can set a PEEP, magical number of PEEP, magical number of tidal volume. How difficult is it to attain that, to know that number?
I think one need to individualize at the bedside. Every patient is different. We can't have the same formula applied to everyone. So I think one needs to individualize the approach, and whether, say for example, an obese patient with obstructive sleep apnea, having an ARDS, having a large belly would benefit from a higher PEEP, whereas a person who is lean and thin might not require a high PEEP. So I think we need to personalize, and that's very important rather than going for a fixed number. Yeah, those are safety limits, yes. We should not cross those safety limits, but the problem with those safety limits are, for example, the plateau pressure of say 25 to 30 disregards the pleural pressure. If we do not know the pleural pressure, so even a plateau pressure in an obese patient of 30-35 may have a transpulmonary pressure which is safe. And I think that is where the problem starts lying. If we kind of blindly apply all those safe limits, then also it becomes an issue. So I think one need to individualize and see how the application of whatever method that we have adopted in that particular patient, how is he progressing on that? We might retract if he is not doing well on that policy. So I think that is the crux of critical care at the bedside.
Thank you so much, sir, for sharing your valuable insights. Dr. Marcus Schulz, sir, I attended your scientific talk today, and it was very fascinating when you actually challenged that tried and trusted component of low productive tidal volume of 6 ml per kg, and you emphasized more on the respiratory rate. Can you elaborate on that?
Yeah, sure. And it's actually a continuation of what the previous speaker was saying. I don't believe in these golden numbers or the cutoffs that have been used by many of us. Let me first say, I don't think medicine can be done according to a cookbook. It's an art, and that means that you have to use the data that's coming from the studies in a good way. It's not the best numbers that come forward from studies. For instance, 5 centimeters of PEEP is maybe only coming because we have 5 fingers. If we would have had 6 fingers, we would have talked about 6 centimeters of PEEP instead of 5. Regarding tidal volumes, I think the discussion over the last 25 years has been dominated by the benefit that was found in one study, the so-called ARMOR trial, or KARMA trial, as it actually was called in the beginning, showing that 6 was better than 12. But now we have much more data coming from other studies suggesting that this 6 is not a holy number, it's not a good number. Actually, by applying a low tidal volume, you have to compensate with a higher respiratory rate. And it could be that a low tidal volume is beneficial, but the higher respiratory rate is harmful. And you have to find that balance in your patients. You can do calculations and think of the mechanical power or intensity of ventilation, however you want to do it. We are not certain yet how to do that, but you have to be aware that you are applying a strategy which may be beneficial, but it's coming at the price of the higher respiratory rate. And this is exactly, as I already said, what new studies are now suggesting. In some patients with a good compliance, a somewhat higher tidal volume can be accepted because you can reduce the respiratory rate, which is so important for the intensity of ventilation.
In fact, Marcus, you mean to say that, yes, that the baby lung concept definitely need to be individualized and personalized variation from patient to patient.
Exactly.
And on that, depending upon the tidal volume, do we still need to monitor and give importance to the stress index equally? Because that is also one factor which has really come up nowadays as far as a factor which should be considered in monitoring all patients of ARDS.
Yeah, it's depending on what you mean and what you think of the stress index. You can really try to measure it, but it's quite complex and it's not always telling exactly what is happening. But you can also think a bit more, let me say, simple and say, if I increase my tidal volume, but the driving pressure remains low, then that patient is obviously probably also happy with a somewhat larger tidal volume, while you can reduce the respiratory rate. And if you apply the calculation for mechanical power, which is, by the way, also complex to do at the bedside, you will see that with that approach, actually the intensity of ventilation, so the mechanical power of ventilation, is going down dramatically. And this is, I think, the way you can go forward. And that's what we are applying now in several ICUs. And there will be a new trial quite soon, the so-called PERMIS trial, in which we are going to test this concept with an endpoint of mortality. It will not only be in ARDS patients, but patients at risk of ARDS, or better said, patients with acute hypoxemic respiratory failure.
Sir, Subhash, sir, would you like to join, sir?
I think we should also realize the reason of, in order to get a positive results, that's why probably the ARMA trial had 12 cc per kg and with 6 cc, because yes, they said that the survey showed that 12 cc was the prevalent tidal volume used at that time. But that also shows that in order to get a positive result, they have to have this kind of a wide gap between these two tidal volumes. Otherwise, if they would have compared 6 to 8, that probably it would have been a negative study, because the power they required probably much larger sample size. So those caveats need to be kept in mind. Yes, 12 is bad, yes, we know, but 6, as Dr. Sul said, that might not be the gold standard.
And to add to that, and I really like the point you're making, you're absolutely right that when ARMA was published, they defended 12 milliliters per kilogram predicted body weight as the number that was being used at the bedside. But don't forget, it was just a mean or a median value. Doctors at that time at the bedside were also smart doctors, and they were using different tidal volume sizes. And it ended up in a median of 12, which was then used or formalized as the control group. But many patients before that were also ventilated with another tidal volume, or a smaller, or sometimes even a higher tidal volume.
Sir, the concept of this respiratory rate, the neglected part in ARDS ventilation so far, do you think it has it is actually the reflection of inspiratory flow rate leading to more of harm or benefit, decreasing the inspiratory flow rate, that being reflected in a decreased respiratory rate?
Could be. I'm not sure about that. It could also be that you say, look, if I cause harm with one breath, I cause twice as much harm with two breaths, and so on, 3 times, 4 times, 5 times. Every breath in this respect counts. And if you have a respiratory rate which can be, with the use of low tidal volume, 6 to 8 breaths higher than when you do not use a low tidal volume, you can do the math yourself. This is an enormous effect on the intensity of ventilation.
Thank you so much, sir. Now, my next question will be for Dr. Subhash Todi, sir. Sir, we know that we have been lucky enough to have you helping in formulation of guidelines of ISCCM. We have got various guidelines. So my next question for you will be, what are the ISCCM guidelines and position statements in pipeline?
You know, when Dr. Pradeep Bhattacharya took over, we kind of got together and we have already published quite a few guidelines in 2023. So we thought this time there were a couple of things we did a little different. First and foremost, we thought that we'll do a focused guideline rather than a blanket guideline on ARDS or a guideline on sepsis management. Secondly, we thought that we'll do something which is important for us, the practical problems that our critical care practitioners are facing. And we thought we'll do it as a grade methodology. You know, the previous guidelines were just collection and experts getting together, looking at the evidence and giving their expert opinion. But the present format of guidelines is to adopt grade methodology. I will give you an example. We thought that multi-drug resistant gram-negative organism is one of the big problems in our country. So we thought that let us make a guideline on that. So we chose 5 PICO questions on MDR gram-negative. I will just give you one example. You know, we do not know the duration of antibiotic therapy, though world over, especially in the Western world, it's short duration. Is it applicable to multi-drug resistant Pseudomonas or Acinetobacter, carba-resistant Enterobacteriaceae? We don't know. So we thought, let's make a PICO question. So the P was a patient with carba-resistant Enterobacteriaceae or Acinetobacter or Pseudomonas. Intervention was antibiotic therapy less than 7 days. Control was more than 14 days, more than 7 days. And outcome was patient-related outcome, mortality, and their length of stay. And so then what we did was we got a couple of people who looks at the literature. They are literature search experts. They are very senior librarians of our country. So we asked them, we gave them the PICO question, we gave them the keywords and the mesh words that we thought was relevant. And they looked at the literature, the big databases, and they came out, say, of this was there were about 1,000+ articles, which we had a team. We screened those titles and abstracts of those articles and came out with around 20 articles, which we had a full text. Those were given to another team who were expert in grading the quality of evidence. So they went through each article and they gave us what is the quality of evidence based on those articles. And now the final stage that we are now is we need to grade the recommendation. We understand the quality of evidence is very low because most of the studies were observational studies, cohort studies, they were not randomized controlled trials. But at least that tells us where are we lacking, where is the lacuna. That will at least give us some research question. And at least we know the world literature is what we are practicing now, where do we stand? So that is how we are formulating the guidelines. So one is on MDR organism. The second is on ARDS, but very focused, like pressure control versus volume control ventilation, and a couple of other things. We have on toxicology, we have on acute liver failure, and we have obstetric critical care. Very focused questions asked on PICO, and there are certain position statements we are making. So that methodology we are adopting, which is an internationally accepted methodology of formulating guidelines. So hopefully, this is a work in progress. So hopefully by middle of this year or end of this year, we'll be having a recommendation based on this literature search and the quality of evidence.
Thank you so much, sir. I am delighted to welcome Dr. Kapil Zirpe sir with us. Dr. Kapil Zirpe sir is head of the department of neurocritical care at Ruby Hall Clinic, Grant Medical Foundation, Pune. He is also past president of Indian Society of Critical Care Medicine and a renowned scholar and expert in critical care. Welcome, sir. So my next question is for Dr. Subhal Dikshit, sir. Sir, what is weaning in its simplest terms? How simple or complicated is it?
In simple terms, liberation of the patient from mechanical ventilation is called as weaning. That's the simple, most easiest way, that removing mechanical ventilation from a patient who is being ventilated is called as weaning. That's the simplest form of definition.
And how do you decide that the patient is fit to wean?
Most important, you must identify the patient rightly who is fit enough to be weaned. You must exactly know the indication for which mechanical ventilation was started. For example, if the patient has got pneumonia with respiratory failure, has the pneumonia been showing resolution? Are the ventilatory requirements gone down? Or if the patient has been intubated for a hypercarbic respiratory failure after failure of non-invasive ventilation, has the pH normalized and has the carbon dioxide level come down with an increased level of consciousness? So you must identify the reason for which mechanical ventilation was started, that has been treated and that has been optimized, and then you can consider to wean the patient off.
Thank you so much, sir. And sir, my next question would be that you talk about the checklist. So how is that checklist approach beneficial in helping patients to better
Most
outcomes?
important, like once you have identified the patient is been fit enough to wean, you must have a checklist in order to avoid a weaning failure. You must definitely see that the patient is off sedation. You must see that the patient hemodynamic parameters are quite okay. The ventilatory parameters, that means the FiO2 requirements, have come down to less than 40% or 50%. In case if the patient is a ARDS who is being weaned off, that the PEEP levels have also come down. So these are equally important parameters you must see. And especially if the patient is being ventilated for a long time and a neuromuscular weakness, snake bite, Guillain-Barré, organophosphorus poisoning, these patients you must identify and look for, one, that is the muscle strength. What is the intercostal muscle strength? Are the accessory muscles working? You must also look for the diaphragms and see how the movement of the diaphragm in order to avoid respiratory failure. And importantly, you must also see that the hydration is quite okay. The cardiac failure or the cardiac pump is quite optimized and it doesn't have any cardiac failure, and pulmonary edema is not contributing to the breathlessness. Check the electrolyte imbalance and also check for the serum proteins, that's the nutrition status, especially in these patients who have been long-standing. Low proteins can give rise to respiratory muscle fatigue, and that can be one of the failures for weaning. So you must have a checklist which is important. You do have certain protocolized targets and protocolized methods which are available on certain machines which really tell you intubate right up to wean. But I would still say protocolized weaning, more important is a personalized approach, and a good clinical examination of the patient plays a very important role for successful weaning following the checklist.
Yes, sir, please.
Maybe I can ask you a question. I would be very much interested about your opinion. Do you think that there is practice variation globally? For instance, is the practice of weaning different in India compared to what we are doing in Europe? And if there is a difference, why would there be a difference, you think?
Really speaking, I have not seen much difference. We still follow the pressure support mode of weaning and a spontaneous breathing trial or a TPS trial, which has been one of the modes of to assess the patients of mechanical ventilation. And if anybody is quite fit enough to be maintaining a support level without any respiratory distress on a lowest pressure support of about 7 to 8 centimeters is as good as a TPS, and he could be ideal candidate to be weaned off. And in case if he's maintaining for about half an hour to couple of hours on TPs without respiratory distress, with less amount of oxygen requirements, I think it should be deemed enough quite a fit patient to be weaned off. Of course, taking into consideration the other checklist parameters like the hemodynamics and the mentation with low level of sedation. That's very important. So I don't think there is much amount of a difference as far as currently what you see. Though protocolized or automated kind of weaning facilities are available more in the West as compared to the as India at present, but I think still a clinical assessment and clinical selection of the right patient to wean off is plays an equally important role.
But it could also be that it's depending on the staffing at the bedside. So having more nurses and more doctors at the bedside makes it more practical to start early with weaning and doing spontaneous breathing trials more often. And maybe India and Europe are more or less alike with regard to staffing, but there are also settings in which there's very little staffing in the ICU. Think of other Asian countries, for instance. What do you think about that?
Well, other Asian countries, I don't know. Dr. Jilpe, do you have any opinion on this?
Yeah, what you said is right. Weaning is not only the protocols, weaning is not only the patient parameters. Weaning is related with the how you are placed in your ICU, what is your supporting staff, what is the nurse to patient ratio, then what is your instrumentation. Like sometimes there are weaning protocols in few of the ICUs in India are the computer protocol driven weaning. But if you talk about the overall low middle income countries, there is a major issue of the staffing is there. There is a major issue of the nurse to patient ratio is there. So no doubt we are following the Europe. There are no major change in the practice, but these factors are affecting on the weaning protocols and the weaning results in a low middle income countries.
Thank you so much, sir. So the next question is for Dr. Kapil Zirpe, sir. Sir, we see that in various studies, still the mortality of sepsis and septic shock range from somewhere around 40 to sometimes up to 70-80%. We have been focusing on sepsis since last at least like 10-15 years with the advancement of critical care and everything. Still, we have not been able to bring down this, improve the outcome. So what do you think are the reasons behind still a poor outcome in patients with sepsis? Sorry.
Yeah, excellent question. If you see over a period of the years, in spite of the n number of the evidence-based studies, the sepsis mortality is ranging from 30 to 80%. In spite of the early antibiotic and antimicrobials, in spite of the adequate fluid challenge, in spite of the source control. So we need to change in the approach. Probably all these evidence-based trials are assuming the sepsis as a homogeneous process, and the homogeneous group of the patients were tried. In fact, the sepsis is heterogeneous. Every patient, every individual behaves differently. We need to understand that particular patient's immune response and the anti-inflammatory inflammatory response rather than putting into the one homogeneous thing. Like if you see the over a period of the years, the definition of the sepsis change, and what sepsis 3 definition we are at present adopting is a dysregulation of the host defense, and dysregulation of the host defense is a immunity. What happens to that particular patient's immunity when any pathogen insult is happening? So probably we need to change our approach from symptom to the system based. Like if you see from 1500 till 2024, last 1 year in 2024, we have changed the approach in terms of finding out through the nanotechnology, the new biomarkers which will pick up the early immune response of that particular individual. And we also noticed that the CNS system plays a very major role in terms of system failure in the sepsis. Like You'll surprised to know how CNS is involved. The central nervous system is involved because there is a sympathetic and parasympathetic drive. And in sepsis, parasympathetic drive get suppressed, and parasympathetic drive is responsible for it. It always keep your inflammation at the bay to the vagal and the splanchnic. So when your sympathetic drive goes in a higher way, what will happen in a surge way? It will produce the hyperinflammation. And that's what the cytokine storm. So all early deaths in a sepsis are because of the innate immunity related with the hyperinflammatory response of the human body leads to the worse outcome. So we need to find out the new biomarkers. We need to change our approach to the sepsis along with the whatever the evidence-based treatment we are doing. So there are so many things are newly evolving. Definitely we are progressing in the diagnosis of the sepsis and the management of sepsis. What is the need of the hour is the new biomarkers and adopting the AI technology to find, or omic technology to find out the biomarkers, which will give us a fair idea about the immune response of that particular individual rather than the overall response of the that category.
Very well said, sir. And we can say that the transition from of an infection to sepsis, that transition period, the timing is also becomes very important. And that's why you said that the need for biomarkers becomes very important. Sir, are there any biomarkers available or they are in the pipeline which you can just throw some light on?
See, we know the all biomarkers sepsis. We need to change our approach to these biomarkers. Like flow cytometry, it is an old technology. It is not a new technology, but it gives a fair idea about the immune cells. What is the immune cells happens to immunity with that. Or you can adopt the omics technology, which gives you the DNA sequencing base, RNA sequencing base. That particular individual's immune response, what happens to his inflammatory response, if we come to know with the help of these new biomarkers with the omic technology, if we combine with the AI, it might give us a real-time fair idea about the immunity of that particular individual, which may helps to reduce the mortality and multi-organ failure in those particular patients.
Thank you so much, sir. Will anyone of other experts would like to add on to this?
I think this is the first step, but the most important step is till now all the immune mediated therapies, whether intracorporeal with all the antibodies to different receptors or extracorporeal therapies of purification, have not been found to be useful. One of the reasons could be again individualization. We kind of assume and give a blanket therapy to all the patients, and that is where a particular patient might not be having a very high IL-6 at that particular moment. To giving an anti-IL-6 to that patient is not going to be helpful. So we need to have a patient's immune profile of that particular patient at that point of time where they have presented to us, and it has to be a rapid turnaround time. So that is where the technology has to evolve. It has to be in the emergency department or has to be in ICU, because we have to act fast. Everything has to be done within 24, maximum 48 hours. And that is, I think, is the crux. We need to find out what immune phenotype, immunological markers those patients have, and then give him that particular therapy.
Yeah, that's what very well said, sir. We need to another timing. Like all trials, all evidence-based trials regarding the vitamin C, steroids, extracorporeal therapies, all are failed, or they have to stop the trial because probably they are seeing it is as homogeneous disease, this sepsis. If they individualize this thing and the timing. Now, sir, unfortunately, what is happening? We are assuming the patient when come to us is a 0 hour. It is not actually 0 hour. It might be the after 24 or 48 hours. And if you try to apply this particular approach, then you might doing more harm to the patient rather than helping them. So timing, the selection of this thing, and in such cases, your omics technology along with the AI may help us to select your drugs. Like we need to know that along with all these evidence-based management, if we select the immunomodulators, non-immunomodulators, and there are certain antibiotic which has the anti-inflammatory actions. If we start them in an early phase, it may help that particular patient.
Like there is a trial going on where they are looking at the onset ferritin level of septic shock patient, ferritin level and HLA-DR4. If ferritin level is high, that patient is hyperinflammatory, and they are treating that with anti-IL-1. And if HLA-DR4 is high, that patient is hypo-inflammatory, and he is being treated with gamma interferon. And so at the onset, so those were the easy markers that can be done. We still do not know what's the outcome of that study.
So again, sir, we are coming to the timing. When you say your innate immunity is there, that is hyperinflammatory, your hyperinflammatory state, your anti-inflammatory drugs will work. That is the ferritin anti. The moment you are adaptive, that means the hypo-inflammatory, you are going towards the drop in the immunity, where you are at this time, if you apply your IL-6 inhibitors, they are going to do the more harm, and that's what happened in few of the patients of the COVID. When this concept get carried away, the majority of patients, probably the timing of the IL-6 inhibitors was wrong, which leads to the more mortality because the patient was already immunocompromised, and these drugs further drop the immunity, and they died because of the this thing. So we need to understand the innate immunity, adaptive, and how, at what time, or how to react to that particular immune response.
So with these new concepts coming in, Todi sir, I would like to discuss with you. We know that yes, early fluid optimization, antibiotic within the first hour, you have found the immune response with the help of rapid molecular diagnostic techniques. You mean to say that over a period of time, will the surviving sepsis guidelines again will also be modified?
Yeah, I think with the technology evolving, it will take a while. I think still we are not there as yet, because not only the diagnostics is going to change the guideline, but the therapy involved with the diagnostics will become important. So that those will take years, to do a proper trial and to see whether there is clinically relevant outcomes. But the concept is that is where we have to go, because most of the trials have failed. So we need to individualize. At one time, the sepsis was pro-inflammatory, followed by anti-inflammatory, but now both of them go at the same time in that patient. In that particular patient, we need to find out.
Marcus, any thoughts on this?
Yeah, I think listening to all the good and strong arguments that came to the table, I think if you would ask the question about ARDS, it's exactly the same answer I'm going to give. So we need to understand better what is happening in our patients. Is it hyperinflammation or hypoinflammation? So, and is it changing over time? So the heterogeneity and the spatial heterogeneity has to be taken in mind, or had to be held in mind when you apply your therapy. And translating this into a randomized clinical trial is extremely difficult, and we do not have the tools yet. And even if the studies are there showing a positive result, we have to translate it to the bedside. How are you going to apply that strategy? It's way more complex. We have a long way to go. But the good thing is we should stop giving treatments to all patients in the same way. Again, it's not a cookbook that we are providing here. You have to do it with some feeling for art and understanding that a syndrome like sepsis is not a single disease, not at the time point the patient comes in, and also not over time. And it's exactly the same for ARDS.
Thank you so much for summarizing it in such a wonderful way, sir, with this wonderful discussion which we had on sepsis. So I think we have time for one more question. So I'll take this. I'll ask this question to Dr. Subhash Todi, sir. Sir, I attended your talk on invasive hemodynamic monitoring. So can you just share your thought here also, that what exactly is invasive hemodynamic monitoring, and what should be the patient selection in which we should go for invasive hemodynamic monitoring?
Yeah, we had a tribate on invasive hemodynamic monitoring, and the theme was, do all patients in shock require invasive hemodynamic monitoring? There was pro and con debate, and I did a balanced view. So at the end of the day, the message was, again, individualization. Not all patients of shock would require invasive hemodynamic monitoring, especially if they are responsive to fluid, they are requiring only low dose vasopressor, and they are getting better very quickly. then they do not require it. It is only a patient who is having higher requirement of vasopressors, multi-organ failure, they will require invasive hemodynamic and advanced hemodynamic monitoring, including cardiac output. So we have to have a balanced view. It is almost like an ARDS. ARDS is, we need to define ARDS after 24 hours. Initially many patients get better very quickly. They might be fulfilling ARDS definition on inception. The same thing is with shock as well. A shock getting better very quickly might not require very invasive hemodynamic monitoring. So I think the main theme across all is we need to individualize patient. Yes, the tools are there. We need to utilize those tools depending upon the patient in front of us, how the patient is reacting to our intervention, and then take it accordingly.
Thank you so much, sir. So I think we can safely conclude that there are no magical numbers, at least not in intensive care medicine. And the more we think about the pathophysiology and the more we understand the pathophysiology and the clinical picture, overall clinical picture of the patient, then we go for a good clinical examination combined with all the investigations, some wonderful techniques coming up, the omics and everything, and then we holistically plan for management, not only on one aspect but the whole patient will only lead to this improvement in the patient outcome. It was a pleasure having you all of you here, sir. I think we had a wonderful discussion, and all our audience will be benefited with this. And thank you so much for all the experts for giving their time, and thank you so much.
Thank you. Thank you.
What you have spoken of, what you will do with this piece.
So like the main
Synopsis, just a brief synopsis of that.
For how long? 1 or 2 minutes?
Yeah, it's total session is for 45 minutes.
No, then that makes it 10 minutes each. So
Yes.
that means
So
it's
in between-
almost equivalent to the talk itself.
but you can ask questions. I mean, maybe it's
I'll
also
ask some
feel
questions.
free to
depending
ask
on what
questions.
you have
Yeah,
answered.
maybe we'll ask questions to each other.
Yeah.
Are we allowed to pass on questions to others?
Yeah,
if
yeah,
they're
yeah.
too
It's,
difficult?
it's not a very
No, I'm sitting with two senior intensivists.
And the
who are-
moderator has to.
to answer finally.
So also-
I'm the junior most person here, so.
Yeah.
So you're the smartest.
They have like two vouchers. They can say, no, I don't take this question.
Hello, everyone. Good afternoon. We are live from Kochi Critical Care Conference ISCCM 2025. And we are in this afternoon session going live on Facebook of channel of ISCCM. And with me are the big stalwarts of critical care, which I'll be briefly introducing. So next to me is Dr. Jiggy Devatia. He's the head of critical care currently at Lilavati Hospital, Mumbai, and he's a past president of ISCCM. Welcome, sir. Then we have Dr. Dewal. He's a surgical trained intensivist from Belgium, and he is active research on optimizing antimicrobial therapies and president of ESICM. Welcome, sir.
Thank you.
And we have Dr. Shirish Prayag, consultant critical care at Prayag Hospital, Pune, past president of ISCCM and Lifetime Achievement Award last year. Welcome, sir.
Thank you.
So I'll be taking the session forward. So my first questions will be with Dr. Devatia. What he is going to speak currently in the current conference of ISCCM. His topic is future of AI in intensive care, moving from predictable to actionable AI. Sir, if you could give a brief synopsis of your talk.
Yeah, thank you, Rajat, and it's wonderful to be at Criticare 2025 in Kochi. So I will be speaking on actionable artificial intelligence, and most of the AI applications that we are used to, and there's a lot of AI that's around in critical care nowadays, but a lot of it or most of it is predictive. You can predict mortality from various parameters. It can be diagnostic, so radiology is full of artificial intelligence, so is pathology. So these are diagnostic or predictive applications. What the next level of AI will be when AI will be able to decide for the intensivist what is the likely outcome if one course of action is taken versus some other course of action. And what AI will do by techniques which I have no idea about, which smarter people, the engineers and the mathematicians and statisticians, they will sort of figure out how to mine this information from big data, from data which is available from the EHR of thousands and lakhs of patients. And using that, they will develop algorithms which will tell you, okay, if I gave fluids followed by vasopressors, is my outcome going to be better? If I give 1 liter followed by vasopressors, I give 5 liters followed by vasopressors, or I give vasopressors first and then give a liter. So it would sort of find out the consequences of various courses of action, and based on that would say that, well, you need to give this patient 1 liter of fluid and then you give a vasopressor. And this it will do by looking at all the data that's available from the EMRs or EHRs of all those systems. So that's actionable. So based on that, how the AI algorithm has sorted out the path, we'll be able to decide which path to take.
Yeah, that's a very interesting talk. And yes, the future of medicine is heading towards AI. But sir, please tell me one thing. Don't you feel that if we are moving too much into AI, would it rob off the traditional aspects of medicine, that it is that the physician-patient centric relationship? How would you comment on that? How will it get affected?
So I don't think we'll lose our jobs, because we still have to, there has to be a doctor who will feed some information into the algorithm, who will have to tell what the potential confounders are and so on. So you will need a medical input there. But even if the algorithm tells you what to do, maybe even you have a robot who's doing the thing you need to do, I don't think doctors will be out of action. And in fact, it will give us time to do what is really important for patients, like talk to patients, talk to families, be with the patients. Empathy is no AI can provide that sort of aspect. We can focus a little bit more on things that really matter, instead of referring to all the major thinking may have been done by the algorithm, but we still have to apply our minds and make sure the right decision is being taken. So it's not going to be completely autonomous. And I think the real role of doctors, the communication, the empathy, the human touch, I think we'll focus a lot more on that.
Yeah, Dr. Diwal, you'd like to comment on that? How do you see AI in intensive care?
Oh yeah, I second the thoughts just heard. I think it's clear that AI will be a tool, and I think we have to look at it as a tool, and that helps us in interpreting risks and assessing a patient. So I'm confident that we will be not replaced, at least not for the first decades. Maybe I don't know what will happen later on, but it can be an important tool. It is, though, very important that as healthcare workers, we do understand how to use it and when to use it. Maybe not understand all the technicalities, I completely agree, but we need to know what the shortcomings are, what the potential risks are. Because if we just blindly believe it without understanding what the risks are, then I think that's a different situation.
Yeah, I totally agree, Dr. Prayag. Sir,
yeah, I think it's a very fascinating area for medicine to be integrated, or having AI as one of the tools in making decisions. As we all know, the data input, the quality of the data input plus the algorithms which are generated or which are initiated by the technologist will also determine, because currently we do find a lot of errors creeping in the answers that we get from the various kind of tools that we have. So hopefully they will all be corrected by the time this gets integrated into practice. And more importantly, it will be very fascinating to watch what will be the legal implications. So suppose you are
heart tells you or your intuition tells you that X is going to be the likely outcome with the intervention, and the AI tells you otherwise, and you persist with what your brain tells you, what is the legal implication of that? Can someone sue you for having overruled AI? And all those technicalities will come into practice over a period of time. So it's a very fascinating area, and I'm looking forward to knowing more about it from Jiggy tomorrow.
Yeah, so I think, and Shirish made a very important point about the medical legal aspects. On the other hand, if you do what AI tells you to do, and there's an adverse outcome, no one can sue AI, right? They will sue you for not figuring out that AI was making a mistake. So either way, you're sued.
And if I may add, I think still we will be required to interpret any proposal as well, because it will be around probabilities and certainties. And if you, for instance, now your gut feeling says, well, this patient may have problems, if I discharge the patient, for instance, or not, then it's very abstract. If the AI system tells you that there's a, just saying 12% chance of readmission, what will you do? Will you discharge the patient or will you keep the patient? If the patient has like 70% of having a positive effect of treatment A, well, will you use it or not? So it will not be black and white. I think there will be a lot of gray, and we will be needed to interpret that part.
Yeah. We welcome Dr. Vijaya Patil, madam. Welcome, ma'am. Madam is a senior intensivist from Mumbai. Madam, your take on that? We are having a discussion on role of AI in critical care. Dr. Devati is going to speak on that in this conference.
I think good discussion happened and most of the points are raised. Yeah, again, my point is the same thing, that you can have AI, you can have all the algorithms, but ultimately at the bedside, your management or your interpretation is going to be different. In the sense, if we look at AI for weaning the patient off, right, the AI is going to look at patient's compliance and resistance and efforts, but it's not going to check whether the patient is coughing adequately or no. It's not going to check whether the patient has got good muscle power or no. So ultimately, somewhere down the line, there has to be also a place for clinical interpretation, bedside evaluation, your experience. Again, the AI is not going to look at what sort of infrastructure you have. So I may have an infrastructure where my patient goes home. In Western countries, the AI will say, okay, this patient is ready for discharge, where they have got a very good community nursing support, which is not there in India. So if that same AI tells us, we are not going to send the patient home because we know the outcome will be poor. So I think there's a long time for us to go for this AI-based.
Yeah, well, very interesting thoughts and very some opinions on that, and we'll be perhaps hearing more on that, discussing more on that in the next lecture when Dr. Devati is going to speak on that. So moving on, my next.
So Jiggy, we are looking forward to a fascinating discussion tomorrow.
I think the discussions happen. You'll have to listen to my lecture tomorrow.
Yeah, but I mean, be prepared for a.
Oh, it's fascinating. It's absolutely fascinating. It's mind blowing, but at the same time, you need to come down to earth. So
yeah, sure,
with your patients.
Of course.
So I think that's the bottom line.
Thank you, sir. Thank you. So moving on, Dr. Diwal, I think your talk in this conference is on precision-based antimicrobial dosing in sepsis, and probably that is the focus of your research as well. So what's your thought on that? Just a brief synopsis of that.
Well, I'll give you my brief interpretation of how this very hot topic of precision medicine, because precision medicine is probably mentioned in every session at this conference. This is also applicable to antimicrobial therapy. Different aspects of antimicrobial therapy. I think it's relevant for making the proper diagnosis of infection and using the proper antimicrobial, but also specifically when dosing the antimicrobial. I think for many drugs, and certainly antibiotics, we've been using standard treatments for every patient, one dose, one size fits all. And I think we learned in the past 2 decades that indeed this results in highly variable concentrations when you start measuring these drugs. And I think we also much better understand now why there are so big changes in these concentrations. It's about the changes in pharmacokinetics. The pharmacokinetics in patients that are critically ill is changed significantly, with often higher clearances from the body because of the augmented renal clearance phenomenon. So that's one important thing to understand, that the way we've been treating our patients results in a risk of underdosing as well as overdosing. So it's on both ends of the spectrum. And this is why we need to do better. We need to be more precise. And my approach to this is that precision medicine in antibiotic dosing is actually driven by our understanding of PK/PD, pharmacokinetics and pharmacodynamics. It is also informed by patient characteristics, and we need to factor in how the patient's body behaves, how organ dysfunction affects antimicrobial concentrations. And the third one is the use of TDM that can augment the precision dosing. So the combination of the three gives you the full opportunity, although it's not necessary to have all of them. I think if you have limited resources, you can already, by what we know now, using simple strategies, do more precise antibiotic dosing.
Yeah. I think that's a very interesting, and I think probably more will be discussed in your talk when you're going to speak on that. And any thoughts on about the role of phenotype versus genotype and precision-based antibiotics? What do you take on that?
Well, that's a bit a separate discussion, of course. I think identifying these different phenotypes is important. Now, when we look at sepsis, so it's a more broad perspective, when we look at the different sepsis phenotypes, I think the challenge and the opportunities are there to identify groups of patients with sepsis who benefit the most from early high-dose antimicrobial therapy. Because also in the surviving sepsis guidelines, there is a general recommendation as to the speed of treatment. But I think we all understand that for some patients, it's really very important to be there even more quickly than the guidelines recommend. Whereas another group of patients, with maybe a more slower development of organ dysfunction, there may be other factors involved, and there may be also not an urgent need for antimicrobials. So we've been looking at different phenotypes in patients with sepsis, but I've rarely heard the perspective of antibiotic therapy. We've been looking at levels of inflammation and maybe patients who would benefit from steroids or other treatments, but I'm confident that we should also that we will also be able to identify those patients who benefit most from rapid antimicrobial treatment. One typical example, of course, is patients with meningitis. There, you need to be really fast. But there may be other phenotypes that we fail to recognize at this stage.
Yeah, thank you. Dr. Prayag, sir, your take on that about the precision-based antibiotics therapy. Any specific areas of focus we'd like to delve upon?
Yeah, it's a very important area for all intensivists to be very accurate about the selection of antimicrobials. But for obvious reasons, many times in order to be extra protective, intensivists do tend to over-prescribe antimicrobials, and that somehow leads to the increased incidence of antibiotic resistance in the ICUs. So it will be fascinating to see how this field of personalized medicines develops into making sure that not only we achieve the accuracy of which medication to be used, but also at the right time and in the right dose, because that is going to go a long way in making sure that the antibiotics are preserved for a longer time as well as being effective.
Right.
What do you?
I think it's quite right. Madam, do you think that we can, like we have discussed about AI, now can these two topics, can we have a synergy in them, and maybe AI can help in having precision-based antibiotics therapy?
Of course, I think that's going to be very, very important. But here you are asking about phenotype and genotype. I think the genotype has got something to do. Like nowadays we have started looking at the genes for typically it's coming beta blockers, the beta adrenergic receptors. They are looking who will benefit from getting the beta blockers in cardiac thing. So even the DNA decides how fast I'm going to metabolize the drug, what's going to be the toxicity profile. So I think that also probably may be relevant to antibiotic as well, because ultimately it's looking at your response, your PKPD as what you are saying, and the metabolism, the thing. So maybe that also will come somewhere.
So your take on that?
Yeah, I think all this information can easily be done by artificial intelligence, combine all those things. But Dr. Yan just said, that you have to have, we know the PKPD, we know the this thing, but I think in my mind, there are two key things we don't have information. One is what is the drug level that is achieved. And I guess TDM will solve that problem, but we don't have good TDM for most of our antibiotics. And I think, for example, we never give noradrenaline without looking at the blood pressure. We never titrate ventilator settings without looking at the SpO2 or the PCO2, but we just give antibiotics based on, X dose or some algorithm or some, area under the curve or whatever that may be. So the other side of TDM is the effect is what is the drug level required to kill the bug. So we need to know the breakpoints or something. And again, we have for many, we don't have for many, and so you can have sensitive bugs, you can have bugs which will die at increased exposure to the antibiotic. So all these unknowns are there, and we are sort of 50% shooting in the dark, even with our knowledge of PK, PD, and so on and so forth. And I guess if all these things can be done quickly, so rapid diagnostics, rapid detection of resistance patterns, all those things will help us in our antibiotic selection. Of course, how to dose them, I think we now have got good data that the PK, PD approaches may actually be superior to, the conventional sort of dosing technique strategies. So I guess we are getting there with rapid diagnostics and so on, but I still think we have some time to, hopefully not too soon, not too late.
Absolutely valid comments and important ideas. I just want to add that now, of course, we're typically looking at dosing to improve outcome. And increasingly, there's also research being done in dosing, not only to improve outcome, but also to prevent resistance from developing. And for this, you may need higher doses as well. And this is just another area of research that is very exciting and that we may see more of in the future. Just wanted to add that. Thank you.
And also about the augmented renal clearance, sometimes we do see in patients of sepsis as well.
Yes.
With high blood volumes.
Yes, sir. So thank you, Dr. Duval. Thank you for that. Changing track a bit, we have with us Dr. Prayag, and so sir is going to speak on the evidence-based use of NIV in this conference. Sir, if you can just highlight the salient parts of that.
Yeah, so slightly away from the previous two talks, it's the evidence-based use of non-invasive ventilation in the intensive care unit. And as everyone knows, it's very commonly used in ICU. And in fact, the industry sources say that India is one of the countries where the use of non-invasive ventilation is higher than the average use in Western world. And perhaps that's because we tend to use it a little more loosely as compared to the absolutely accurate scientific way in which the Western intensive care units operate. So there are certain situations where there is a definite indication and a definite place for non-invasive ventilation. There are certain definitive contraindication, but the amount of gray area is quite a large one. And it is that area which needs to be explored and understood by the people. So the title says evidence-based use of NIV, and if one has to be absolutely thorough, then one needs to talk on the devices, the tools that we use, etc., etc. But we don't have time for that tomorrow. So what I'm going to focus in tomorrow's talk is actually the clinical indications, clinical settings in which we should be using the non-invasive ventilation, and what should we be looking for when we are using them, and when should we stop those. So actually to enhance the clinical decision-making ability to use non-invasive ventilation accurately and stop its use when we identify that it's not helping or it's not likely to help over a period of time, to stop its abuse. That's the way I'm going to handle it tomorrow.
Yeah, I think, sir, that's very well put. And probably that is the area which now we need to focus upon, about when not to use it. And madam, your thoughts on that, about the use of NIV, how do you say that? Is it being overused, or we are still, especially like in resource limited settings? What's your take on NIV?
If you ask me about our country, it's so heterogeneous. The infrastructure, the knowledge, the support system is so heterogeneous that I can take a particular risk in Tata Hospital where I know I have got DM candidates 24-hour good. That risk cannot be taken in some remote place where you know that you don't have that good monitoring. So I think, as again what Sir is saying, yes, we are, at many places I have seen that NIV is abused. In the sense, people just go on and on in the hope that my patient would respond and will recover and I don't have to intervene. So I think this has to be somewhere down the line. You have to consider what your surrounding is. So I may probably say hypoxemic respiratory failure, but let me observe, let me see. These are my points when I'm going to intervene. Have a good protocol in place, the guidelines which has been adhered to. That may not happen at other places. So how you take the risk taking depends on the surrounding factors. So then you can.
Yeah, sir, what do you say about like our use of NIV? Like we had recently COVID epidemic, and it was hotly contested about NIV. So some were strong proponents, some were totally against it. So how do you see it, sir?
So let me put the pre-COVID or the non-COVID use. I think, as people get more and more experience with it, they tend to do things that earlier were sort of, you should not have been using it. So I see it used very commonly for hypoxic respiratory failure, although the guidelines would suggest that, beyond a point, it's not very good for acute hypoxemic respiratory failure. For example, malaria, or dengue or something like that. But again, there can be a justification because these sort of diseases are treated in nursing homes, and they may not have the kind of expertise for invasive ventilation. But yeah, I think the key is that we have to know when to stop NIV and when to cut our losses and switch to intubation, no matter what situation you do it in. Right. In COVID, I think it was a completely different environment and situation. I mean, there were so many patients who needed respiratory support, and you didn't have enough qualified people who could do it. And obviously, intubation was not going to be possible in many situations. So non-invasive was probably the least bad option, and in many situations, and it did maybe save a few lives. Maybe we lost a few lives, but I think at the end of the day, no one should go away feeling that NIV is something which is very simple. Anyone can just stick on a mask and your patient will be fine. It does need level of expertise, need a level of monitoring, and we need to know when to switch to invasive ventilation.
Yeah. Dr. Dewal, how do you use NIV in your practice? How do you say?
Well, to be honest, we don't use it a lot in my practice. I think we mainly use it for short-lived treatments for acute decompensated heart failure or acute COPD exacerbation. But in the other situations of progressive respiratory failure, and then dengue and malaria, we don't treat this kind of indications, but just more general, that in those situations that patients progressively deteriorate up to the point they may need intubation, I think the use of high flow nasal cannula, high flow nasal oxygen has replaced it. Essentially for those indications, and if that fails, we would go to intubation. And no longer have this step of non-invasive ventilation in between. That's my experience.
Yes, great. Right, sir. So I think we'll be having interesting discussion on that tomorrow. So all are requested to please attend the sessions so that they can have more insight to these in a detailed manner. Sir, you like to say anything else?
No, thank you.
Okay, sir. So, madam, I think your talk in this conference is going to be on the selection of vasopressors and inotropes, what and when. I think it's done. It's done, but those who are not attended, for the benefit of those, because we are live on the Facebook channel of ISCCM. So if you can just highlight what your take-home messages for the audience.
I think regarding the choice of inotropes and vasopressors, more or less the literature in few aspects is very clear. We have got guidelines from Surviving Sepsis or the European Journal of Heart Association or from AHA. There are some gray areas like when will you start vasopressin, how much maximum dose of noradrenaline will you give, will you taper vasopressin first or noradrenaline first. In this, again, there is not much in terms of evidence. If you talk about RCTs per se, more or less observational trials, the practices differ, and whatever the data which is emerging currently is ambiguous, that you may not. So ultimately it comes on that. But what I feel, when you start any vasoactive agent, it's very important to understand the underlying pathophysiology. And that's true for every aspect of critical care. So I think a good person who understands physiology will be a good good critical care physician. So looking at the numbers, looking at your the patient's evolution, understanding what's happening underlying, what is the pathophysiology, you can select your drugs wisely. And again, close monitoring when you start a drug, in which direction the patient is moving.
What is your take on some people are now saying that like patients with sepsis with LV dysfunction use a noradrenaline along with say dobutamine or milrinone. So what's your take on that, ma'am?
So norepinephrine is still the first line of treatment, but yes, we know that the literature, again, you look at the incidence of septic cardiomyopathy, it varies from 10% to 70%, depending on how they have been monitoring and what they are looking at. So we know that it's a large amount of patients also get the septic cardiomyopathy. So monitoring, and if the patient is really, really very sick, the heart is functioning very poorly, one may consider adding dobutamine. But again, if you ask me the evidence, it's not their level 1 evidence. Again, it's just basic understanding as physiology. If my patient on norepinephrine is holding on and the patient has got septic cardiomyopathy, one may try adding a touch of dobutamine.
Dr. Devatia, sir, your take on that about the use of say, vasopressin along with high dose noradrenaline, whether you use it or, so for example, patients with high pulmonary artery pressures would like to add epinephrine as proposed by some of the cardiologists, cardiac surgeons. They are little fond of using epinephrine. Now, what's your take on that?
I don't really have a take on that. All I would like to say is that, if you find that you're having escalating doses of any vasopressor, whether it's adrenaline or noradrenaline or vasopressin, I think you need to monitor the circulation better. I think empirically stepping up or arbitrarily adding one or the other, the initial steps are fairly straightforward. It's noradrenaline and then vasopressin, maybe then adrenaline. But if you're worried about things like pulmonary artery pressure, pulmonary hypertension, and you're just escalating your doses, you need two things are happening. Either the patient's getting really sick, or you've not given enough fluid, or you've not got your diagnosis right. So I think you need to monitor and reevaluate at that point in time. And it may mean stepping up your level of monitoring. Maybe simple echocardiography may give an answer. Maybe we need to do invasive cardiac output pressure. If you're suspecting pulmonary hypertension, even in this day and age, I think pulmonary artery catheters could be pretty useful. So you need to decide what you need to do. I think to answer a question, okay, this is not working, add that. If that is working, add something else. I don't think we should be going down that path.
Correct.
And if I may add something like, you're basically, because we're talking about adrenaline or epinephrine. So now there's a signal coming out from many studies that it's not that good. So if you look at Optima trial, where they looked at adrenaline versus noradrenaline in cardiac shock patients, cardiogenic shock, the adrenaline was associated with more incidence of resistant shock. If you look at the study which looked at post-arrest, post-resuscitation using norepinephrine versus epinephrine, they found that norepinephrine was much better. And in them also, again, the patients who died, the cardiac-related mortality was much more in epinephrine-related group than in norepinephrine group. So I think though epinephrine is our baseline, the body's endogenous inotropes giving exogenous, plus it has got these metabolic effects of hyperglycemia or lactic acidosis. So probably now it's a time looking at these studies. Some of them, most of them are observational except Optima. I think there is a time to look back whether I really need to add epinephrine or anything else.
Yes, ma'am. Dr. Dewal, your comments on this?
Just some thoughts. I absolutely support the concept that when a patient is deteriorating, you have to revisit your diagnosis, check whether your sources of infection have been controlled adequately. And of course, at the same time, you need to escalate the vasopressors as well. But in parallel, think of what is happening in this patient. We would indeed also add vasopressin at a certain point. I don't know the magic number as where you should start this and where this really makes a difference. I often have the feeling you replace one vasopressor with another one. So overall, your norepinephrine dose goes down. So you have this kind of good feeling inside, but whether this translates into improved outcomes, I'm unsure. But yes, we would do it, and indeed be careful with epinephrine. And always, we talked about precision medicine earlier, but always think of the context. Are you dealing with an elderly patient who had recent cardiac surgery, or are you looking at a young trauma patient or a burns patient, whatever? I mean, think of the condition of the patient when you add or remove vasopressors.
Right. So, Dr. Prayag, sir, in the wake of now coming a lot of circulatory support, which is there, and people are saying that once the patient is on getting on high dose escalation of vasopressors in septic shock, cardiac shock, one should look at the circulatory support like ECMOs, intra-aortic balloon pumps, etc., etc. So, what do you suggest, sir? What's your thoughts on
Well,
that?
they have their own place and their own indication. So I'm sure we can't generalize and say that at X level we should be going over onto these support medication. It's as much a pharmacological support versus a mechanical support. So we should be looking at it objectively from that. But the main point is, I agree with Vijaya, is that we should be able to understand the pathophysiology which is going on in the given patient who is in front of you. For example, not every septic shock patient will have the same kind of vasodilatation. Not every patient will have the same kind of myocardial dysfunction. And as a result, the agents that we tend to use will need to be varied accordingly based on what actually that patient is showing, plus their pre-medication in the sense that if they have been steroid dependent or not. So all these components will play a role in the selection of the vasoactive agents. And it will be a fascinating area to explore even in future regarding the appropriate use of vasoactive agents in the intensive care unit.
Yeah. So you'd like to say something?
I just want to make one additional point last. I mean, when you're talking of vasopressors, we are always looking at blood pressure, but I think I would urge everyone to think of cardiac output and very importantly, tissue perfusion. So also look at whether stepping up the blood pressure or giving the vasopressor is not having an adverse effect on tissue perfusion, because that's one thing you need to. So your ultimate goal is not blood pressure, ultimate goal is tissue perfusion. So make sure that remains your.
So, yeah, I agree, sir. Probably in view of the so much of patient heterogeneity, as sir has pointed out, the role of precision-based medicine and use of AI probably will help us in deciding the use of vasopressors, maybe in down the line, 10 years down the line when we are more, have more evidence on that. Dr. Deval, your talk is also on another little side different topic about environmental sustainability, time for collaboration. It's a little different topic from the conventional critical care. I'd like to develop on that.
It's indeed a little bit a different topic, though I think very important and universally applicable. So in my presentation, I will briefly outline that it's not only about how climate change and environmental sustainability is important in determining our activities in the ICU with more heat-related disorders, with more trauma maybe from catastrophic events. It's also about how our activities in the ICU impact the environment itself. And about this global movement, and I'm also happy to see here that indeed sustainability is actually in the subtitle of your annual conference here in Kochi. So it's also more about how can we modulate the impact we have on the environment and gaining more insights. This is still a relatively new item, and I think we lack a lot of evidence. So therefore, in my talk, I will call for a united approach and doing more research together. Also making sure that all healthcare workers really understand how their activities and what they do may impact the environment, and that there may be opportunities to reduce it. And let me be very clear, without decreasing the quality of care, because often I hear comments, well, if you are more sustainable, then you will degrade the quality of care. I think this is not the case. In some situations, it's even the opposite. I think many things we are doing actually add very little, and there's a lot of debate around the low value care, as we call it, things we do on a daily basis, but that do not add anything. For instance, routine chest x-rays, routine lab tests. I get many times people come to me, nurses come to me, and they give you an arterial blood gas, and you're like, well, was this really necessary? Often it is not necessary. And an Australian study showed that 30 to 40% of the blood gas analyses actually do not bring any additional value. So there's a lot of opportunities. I think there's a lot of opportunities to learn from each other. And I think it's also very important to learn also when people work in low resource setting. For people working in high resource setting, it's interesting to see how people with low resources actually are able to deliver the same level of care. So a lot of discussion, points for discussion, a lot of insights to share, and definitely a topic that will remain on the agenda. From ISCCM, we've released recently our green paper, which is kind of a template to inform, to educate healthcare professionals, to really offer practical solutions, as well as to also get our societies, the organizational part of our societies, to become more sustainable.
Yeah, we're looking forward to that. Very interesting talk. And as you rightly said, sir, it's a need for a global collaboration on that. Dr. Prayag, sir, your take about, as Dr. Diwal has mentioned, in Indian context, probably we're looking at the large amount of biomedical waste which we are producing. What's your take on that? I mean, it's a big problem in Indian settings, maybe not that much in European countries because they are quite expert in recycling, but we are not, unfortunately, reached that level. So, sir, what's your take on that?
Yeah, I think it's a great question, but let me go back to the statement Vijaya made some time ago that it's a very diverse country and the resources are diverse, the practices are different, the expertise is different, the knowledge sets are different, and therefore it's impossible to define one principal action and then ask everyone to follow that. And that's the reason why a lot of these protocols are not adequately followed or maybe overridden. For example, in a rural area, the myocardial infarction may be monitored by more often ECGs as compared to a continuous monitoring with recordings. Or the blood gas analysis may not be available, and then they would depend more on the pulse oximetry, and so on and so forth. So the generation of biomedical waste will also be a byproduct of what they are doing, and that will be completely diverse. So it will be fascinating again to actually educate people. I think that's the way we should begin, by educating people about what the need is and how they are going to make sure that they optimize their own resources according to the needs and produce the least amount of environmental effect on that.
Yes, ma'am. Ma'am.
Yeah, I'm quite sensitive about this issue, and I'm really a strong environmentalist. I think in the name of patient safety and in the name of saving yourself, the defensive medicine that we practice, we really do lots of harm to the environment. We do not look at, or we never consider carbon footprint of our actions that we are doing. For example, as he was mentioning, it's I attended one of the webinars in between where some researchers had taken really pains and she had calculated the carbon footprint of one coagulation test. And it really was an eye-opener, saying that every activity that we do, because I just consider the cost that my patient or my hospital is incurring, but you don't look after the carbon footprint of the manufacturing of that thing, the reagents, the disposables that you are using. So it's really a huge thing. So instead of looking at only cost, we should look at the environmental harm that we are generating. Second thing, again, in my experience, what I have seen is we as medicos, we are very not bothered about waste segregation. Like, we don't understand that if I got a plain plastic which can go for recycling, I'm doing much better the environment. Everything will go together where infectious waste not. So that has to be right from the time go in the medical school. These things have to be inculcated into their daily practice. Like many that you see, your ventilator, the patient is extubated, it's kept on the standby. The electricity that is using, or no one has looked at it or no one calculates it. So probably even if we start that whatever is useless, I don't know whether it's environmental friendly or environmental harmful, I should not be doing it. I should somewhere down the line, everything that I do, I have to justify myself that why am I doing it or what is the use it. Maybe that will also go a long way.
Very rightly said, madam. Sir, Dr. Devatia, your said on that, what Dr. Diwal and everybody else says.
So, I think there is no question that there is a lot of awareness that the way we work has been damaging the environment. It has been, that's a side effect, or maybe a very bad side effect of some of our practices, and the equipment that we use, and and so obviously we need to do something about it. And the mantra is the usual: reduce, reuse, and recycle. The question is, how much can you reduce, how much can you reuse, and how much can you, and what can you recycle? We also need to be aware that quick fixes. For example, in the anesthesia literature, they said stop using desflurane because it's got huge amount of global warming potential, and it stays on much longer in this thing. But so now there have been arguments for and against. I would actually support what Dr. Jan de Waal said, is that of course we need to do research into what is causing a problem. We also need to do research into the solutions that we propose to make sure that they don't have some collateral damage, because there are lots of things like Dr. Vijaya mentioned about coagulation tests. It's not just the test, it's not just throwing away that strip of paper or that the blood in your vial, in your vacutainer, but it's also about the power, electricity, what went into making of the reagents and all those things. So same way, if you propose some alternative, what are the implications of that? So the entire life cycle of that event or that solution we need to evaluate as well, and then we can find what is the best answer.
Yeah.
It may be that what we are doing is maybe not as bad as the solution, maybe the solution, or we may actually come up with a very good solution, right? And the only other point I would like to make is that all this is absolutely vital to bring awareness, but we must find reasoned and research solutions rather than aim for supposedly quick fixes, like that sort of thing.
Yeah, I think so. We are very, very right. And probably looking into the carbon credits like we have in industry, now it has become a norm in many non-medical fields. Probably something like that may be considered in medical field as well. Dr. de Waal, what's your take on that?
Well, that could be considered. I would just fear that when we look at what we do in the ICU and the intensity of the care and the resources we need and the outcomes we get, I fear people may just close us down, to be honest, because I mean it's the reality. We use a lot and our footprint is large, but I'm not advocating, of course, that we should stop our activities. Let this be very clear. I agree also that we may be able to reduce, but we will not be able to completely get rid of any emission. It's just that there are opportunities of things that are happening and that are really not helping the patient, not helping us, maybe sometimes even creating more work and more investigations. If you do too many lab tests, maybe then you may do more CT scans because you are worried about a certain trend you've seen in a biomarker, which essentially was not necessary to determine. I mean, it does have a lot of consequences down the road. So the idea of the credits, I think, just that our
still, yeah,
our profession is will remain at the top, but it doesn't mean that we maybe can improve with 10, 15, 20%. That could already be a huge impact, and that's still a responsibility that we should take.
Right. Thank you.
Make one more quick comment, if I may.
Last.
So I think, and we must look even beyond our routine day-to-day activities in the intensive care. So remember, we are all parts of hospitals, right? And Dr. Vijaya heads a large department in a big hospital. So her responsibility is even more. She has to look beyond the patient and she has to look at the infrastructure. A lot of the carbon footprint is accumulated because of air conditioning. So whether we can have solutions for things like air conditioning and lighting and electricity and power generation. I mean, so all that's part of our hospital environment.
Yes.
All that we needs to be looked into. Maybe not doing coagulation tests or X-rays may save X, but maybe you could make a huge saving by changing the way you do air conditioning or your power generation for solar energy or whatever. I mean, so we need to look at that aspect as well, the engineering and other aspects as well.
Right.
I'll just make a quick comment before we finish off. I think just to complete the circle of your discussion, I think this carbon footprint needs to be included in the AI algorithm before they take a decision.
Very right, very right, and probably yes. So yeah, so I eventually find out that all our talks, which eminent speakers are saying, are all interlinked. And yes, we have found that. And thank you, ladies and gentlemen. And it was a very wonderful lecture. Now I'm sure all our audience we have gained rightful insight into that. And thank you once again, everyone. Thank you, sir. Thank you, ma'am.
So, yeah. So good evening, ladies and gentlemen, everyone. Welcome to this Criticare Live. I think one of the very innovative and new concepts during this annual National Congress of the Indian Society of Critical Care Medicine. And I have the privilege of having 4 experts along with me for this particular session. And we're going to talk about the different deliberations that they have got for this national conference and also a lot of insights that we'd like to share with all of you. So let me introduce you, starting from my immediate left. I would go ahead with Dr. Ram Rajagopalan, and he's a professor and head of clinical services, Department of Critical Medicine at Sri Ramachandra Medical Center, Porur, Chennai. Welcome, sir. A lot of accolades. He has been the past president of ISCCM, and he has been the founding member, executive committee, ISCCM, Chennai branch, and all of it adding on to his mentorium, coordinator of the DNB curriculum in critical care. He's associated with the National Board of Critical Care Medicine, New Delhi, and his areas of interest include cardiopulmonary resuscitation, sepsis, ventilation, hemodynamics, and critical care foundation, not to say the least. So next we have Dr. Sheila Nayanan Maitra. She is a well-known figure with critical care. She's a professor with critical care medicine, Tata Memorial Hospital, Mumbai. And she has been the immediate past president of ISCCM, the first lady president that we had in ISCCM. And she's the chair of the ICM committee of the World Federation of Societies of Anesthesiology, the WSA, and a past president of the All India Difficult Airway Association. And she has also been appointed on the International Surviving Sepsis Campaign 2025 Guidelines Committee and the SSC Research Committee. She also is a part of the steering committee of the Asia Pacific Sepsis Alliance, and among the 14 international airway experts on the ASN Puma Difficult Airway Guidelines, she happens to be one of the esteemed members. Now, also we have with us Professor Dr. Praveen Kumar Jain, and he's from Mumbai, and he's the founder president of ISCCM and also the founder editor-in-chief of IJCCM. He continues to be the chairman and was earlier working with the Critical Care Foundation, Education Foundation, in fact, and started ISCCM in 1993, one of the members there, and also a part of the start of the IJCCM in 1995, along with CCF, and being a part of the College of Critical Care Medicine. His area of interest include teaching, that's quite evident, ARDS, and electrolyte disorders in ABG. We are also esteemed to have with us Dr. Bram Rochberg, and he is an associate professor. He comes from Hamilton, Ontario, Canada, and he's an associate editor with Critical Care Medicine, the vice chair of Canadian Critical Care Trials Group, vice chair of the Surviving Sepsis Campaign, and he has more than 440 index publications with a high impact factor. And his area of interest are sepsis, acute hypoxic respiratory failure, a lot of randomized controlled trials, meta-analysis, and clinical practice guidelines. And he comes from McMaster University, Canada. So I welcome all the 4 esteemed speakers and experts with here who have joined us here. And what we'll be doing is we'll be taking you through the different deliberations and presentations that they have and the expertise that they are going to share with us with the different insights and what's there in the different topics that they have been taking and covering in this critical care conference. So to start with, I would start away with Dr. Ram Rajagopalan, sir. And he's been here and he's been talking about the different challenges and limitations of the definition of the previous one, the critical guidelines that we had about acute kidney injury. So to start with, sir, maybe just want to know from you, what were the challenges and limitations of the guidelines that were put up maybe a decade earlier, that was in 2011-12?
Okay. Please understand that you may call me an expert, but I'm just as much of an expert as maybe Harsha Bogle, who's never played cricket but talks all the time about cricket. So very, very clearly, there is going to be a limitation in what I'm going to express at this point in time. Okay, let me just go back to the last formal guidelines that were published was the KDIGO guidelines That was almost, as you said, almost a decade ago. And it was based on what we may consider reasonably practical kind of measures, both the measurement of the urine output and the renal and the serum creatinine, as a serum creatinine being a better way to express creatinine clearance, since we can't be calculating it on a very regular kind of a basis. So this was the basis of what we did, and it was reasonably a practical guideline which did take into account a lot of other issues related to the previous guidelines. So for instance, the initial rifle guidelines required that you need to know what the baseline creatinine was for you to make a judgment whether the patient had a change in creatinine, and that was felt to be difficult to do. The second aspect of it was also the recognition that small changes in creatinine were associated with major changes in outcome, and as a consequence, a smaller kind of a threshold was used of creatinine rises of 0.3 was considered as a significant enough rise. And along with that, the urine output criteria, quite honestly, if you really look at the urine output criteria and a 0.5 ml per kg body weight kind of a limit that it places, is a theoretical limit. I don't think anybody really knows what is definition of true oliguria. And it's based on the presumption that that will be the minimum amount of urine that you need to produce if you had a normal solute load and the maximum ability to concentrate your urine, which again is going to be something that is not very common in a patient in the ICU. They don't have, they have solute loads that can be significantly larger, and they don't have the normal concentration ability, primarily because of their underlying disease and maybe the treatments that they get. But irrespective, these were the two sets of parameters that we used, and ultimately we also found that as we continue to use this, that there is a problem with the sensitivity of both of these parameters. Now, first of all, creatinine particularly is something that comes as a delayed rise. And for identification of renal failure with a creatinine is going to be definitely delayed if you're just going to use that kind of a measure. So the sensitivity does drop to some extent. And the urine output, as I said, is rather a arbitrary kind of a guideline that we've been using. That a large number of patients with renal failure probably will have even normal looking urine outputs, and there's a possibility that it could be missed. So under both of these conditions, the sensitivity was something that was lacking. And ultimately, I think the biggest concern that we had about these definitions were that they were defining renal failure not on the basis of the injury that was occurring at the kidney, at the level of the kidney, but rather the consequence of the injury. Or in other words, the argument was always like treating heart failure, identifying myocardial infarction after the development of heart failure, for instance. And obviously that was insufficient. There was a strong feeling that we needed to improve the sensitivity of this diagnosis. And the one way in which this could have been done is probably by the addition of biomarkers, which were one of two kinds. One set of biomarkers will be markers of injury to the kidney, and the others will be effectively markers of the filtration efficiency of the kidney. So as substituted measures for creatinine, you could use something like cystatin C. And for biomarkers of injury, you had quite a variety of biomarkers that were present. And what was very interesting is while this was seen, that many patients who didn't have a rise in their creatinine itself would show elevations of biomarkers. And what was very visibly seen is when they did have these elevations of biomarkers with a normal creatinine, their outcomes were definitely worse off than normal patients, suggesting that it was an early form of the renal injury. So as a consequence, this has been something that has been incorporated into the guideline, and the staging of renal failure, which used to be based on your creatinine and urine output initially, has been additionally modified by the inclusion of these biomarkers also. So there is a definition of what they call as subclinical acute kidney injury, where you have normal creatinines and probably normal urine output, but you do have an elevation of the biomarkers, and that would be a consideration for the early diagnosis of kidney injury.
Yeah, thank you so much. So just to add on the same point, so we had the KDIGO, which came after the Akin and the rifle criteria. Now, more or less the parameters were the same. It was a little made a little easy, or maybe it was put more specific when we talked about the KDIGO.
It certainly, both of them were made more sensitive.
Yeah.
In the sense that in the KDIGO, certainly when you look at the AKIN, they used a more difficult cutoff. They used a 0.03 kind of a cutoff. And in the KDIGO, there was actually a little bit of a compromise, saying that the duration of time was the thing that was varied.
Correct.
Okay, I think there was a feeling in the AKIN that it should be defined with a 48-hour rise. This said you can go even with a 7-day rise, primarily because you'll miss a few patients when you do that. Both of them increase the sensitivity quite significantly.
So you talked about the biomarkers coming to play here, because that time, even when this guideline was reinstituted, when it was put in across, there also the studies were there, but they didn't have much of studies at that point of time regarding the biomarkers, the functional or the ones which could be telling about what's the damage that's to be done in the kidneys. So now, talking about this particular guideline, what is the acceptability or the feasibility of this guideline? Because serum creatinine, urine output are easy bedside measures, or the basic test which can be done. What about the implication or application in resource-limited settings where you wouldn't get the biomarkers?
Yeah,
it's quite difficult.
very seriously, it is a concern. The fact of the matter is, even if there are simple card tests that are available elsewhere in the world, I don't think we have the option of being able to measure the biomarkers on a routine basis. Quite honestly, like I said, I'm the Harsha Bogle, and I'm going to talk about things that other people do. I have not done that myself.
Right.
So I think that does continue to give the limitation to the.
So basically, if you have to see, we continue with the KDIGO till the biomarkers don't become a daily kind of a usage item for all of us across.
But I also want to, sort of remark on the fact that even though we talk about biomarkers in general, the question is, do we understand these biomarkers well enough to make a differentiation between the varying biomarkers, or even looking at the kind of similarities some of these biomarkers may have? I don't think we know that well enough. So
yeah, more than that, yes, absolutely right. More than that, we need to understand what the limitations of these biomarkers in terms of how can you generalize it or how can you apply it. In terms of just having a biomarker doesn't have a solution or a straightforward answer. So we'll get back to you again, sir. So I'll take it forward, Dr. Sheila.
Thank you.
Yeah, so she had a nice presentation on the physiological difficult airway, the updated guidelines and management of the same. And we know that you've got a lot of work done about it too, ma'am. So can you just brief us about as to what we have always heard about anatomical difficult airway? Now, what is a physiological airway?
Right, thank you so much. So like you rightly said, we've been very focused on anatomy, and we've always thinking about how you can technically get the tube in, and we've been quite obsessed with this. Now, the physiologically difficult airway is not a new entity, it's just a new term. We've always had a physiologically difficult airway, but we've tried to define it, and there's been more focus on this entity now, especially in critical care. So what we mean by the physiologically difficult airway, and recently through the consensus statements that we made through a robust Delphi process, we were able to get international airway experts in airway management in the critically ill come together and form consensus statements on not only the definition but also a management practice for patients with a physiologically difficult airway. So the consensus definition was that a physiologically difficult airway is one in which either physiological or pathophysiological alterations in the patient increase the risk of complications during tracheal intubation and transition to positive pressure ventilation. So this was an emerging definition. It was taken forward from just critically ill patients that was defined in the emergency department to even patients, not patients who have physiological alterations, like those patients who are pregnant or someone who's obese or even children who have a short apnea time, their FRC is reduced, and they desaturate very rapidly when you try to do a tracheal intubation in these patients. So the definition has just been expanded, a lot of focus on this, but the entity, it's always been there. So it's just to focus more on this that we have a definition and call it physiologically.
So according to you, what are the different causes, ma'am, where these patients develop a hypotension? What are the different causes which will result in this?
So the most common complication is hypotension, but there's hypotension, there's hypoxia, more severe complications like cardiac arrest. And in critically ill patients, the pathophysiological alterations, like they may be already hypoxemic, they may be, hypotension, right ventricular dysfunction, patients with raised intracranial pressure. For instance, if you have a brain injured patient and the ICP is raised, and you try to do a tracheal intubation in this patient, and if you're not careful, and if you increase the raise, because of the pressure response, you will increase the intracranial pressure, and that will lead to more complications. So these physiological alterations in critically ill increase the risk of complications. And it's not just about technically not being able to get the tube in and hypoxia that we were previously very worried about. So we really have to be cognizant about this entity, because like they say, the eye does not see what the mind doesn't know. So when you know that these patients are at a high risk, then you'll take precautions to optimize their physiology before doing a tracheal intubation, so that you can mitigate the risk associated with the tracheal intubation.
So I think, based on your research and your presentation, a lot of insights and a lot of awareness has come about as to this particular aspect, because everybody has to deal with it on a day-to-day basis, and that would really throw a lot of light on how we can prevent the complications and avoid catastrophes which really do happen during intubation. Ma'am, anything more that's going to happen? Any research which is underway, or anything more that's going to come on this aspect?
Right. So in the INTUBE study that was published in 2021 in JAMA, and that was led by Vincenzo Ruzzotto, and I was also part of the study, it was a global prospective observational study actually, but it looked at data of almost 3,000 patients, and from both developing countries and the developed world. And it was one of the first studies that looked at global data. Until this time, we only had data from high-income countries, or single-center studies, or national audits is what we had. And what this study showed is that the incidence of complications are high, as we already knew. It was about 45%, but unlike what we imagined, it wasn't the hypoxia, but it was the hypotension, cardiovascular collapse, that was more frequent during tracheal intubation, critically ill patient, and as high as 42%. So that almost means 1 in 2 patients who we're intubating has cardiovascular complication or hypotension. So it's something that we really have to be aware about, and not take these intubations very lightly. And now that we've identified that it is the hypotension, and hypotension is really real, what do you do? And the other thing that the paper showed, which was really important, is that if you have an overall complication, any complication, or if you have a cardiovascular collapse, this is associated with increased 28-day mortality. Now that becomes very serious, because it's not just some complications, something that briefly happens during the peri-intubation period. You have hypotension, you teach it with vasopressors, or you have some hypoxia, you reoxygenate the patient, and you're fine. If this has a bearing, this complication that occurs for a short period has a bearing on 28-day mortality, then it's something that we should prevent. And of course, we have to treat it, but we should try to prevent this complication. Now, what's happening is the hypotension is real, 42%. And conventionally, what we've been doing is we've been giving fluid bolus. We know that there's hypotension, of course, not to this extent, but we've been giving fluid bolus, about 500 ml of saline prior to tracheal intubation, knowing that these patients are likely to have hypotension. In fact, even in the intubation bundle that was proposed by Professor Jaber, giving 500 ml of saline was very much part of the intubation bundle. So we've been doing this, but this hadn't really ever been tested in the randomized control trial. And that's what the Vanderbilt group actually did. They did a randomized control trial, and they gave 500 ml of fluid in one group, and the other group was usual care. And interestingly, they found no difference in the incidence of cardiovascular complications, whether or not you gave a fluid bolus. In a subgroup of patients, they found a benefit of giving fluid when a positive pressure ventilation was used. So if you used NIV for pre-oxygenation, or you gave gentle mask ventilation during rapid sequence intubation, there was a benefit of giving fluids. So they went ahead and did the PREPARE-2 study, and using only, taking only those patients in whom positive pressure ventilation was given. And interestingly, even in that, they didn't find any difference. So all along, what we've imagined that fluid, of course, there were limitations in the studies, but we've imagined fluids, give fluid and prevent hypotension. That doesn't seem to be working. So the incidence of hypotension is high. Fluid bolus doesn't seem to be working. So we have to look for something else to prevent this. And the other thing we could do is, alternate thing we could do to bring the blood pressure up is to give vasopressors. So that's where the research is headed. But again, giving vasopressors is not so simple. Because if you try to preemptively give vasopressors, when you do a laryngoscopy, there's a pressor response, and that itself increases your blood pressure, and that could increase. So if you give a vasopressor, you might land up with a hypertension, and so it can be quite tricky. So we've talked about using very low doses of vasopressors, and of course all patients don't have central lines when you do a tracheal intubation in the ED or even the intensive care unit, so we have to give it through a peripheral line. So at the moment there are two studies. One has been completed. That's a FLUA study that's just completed in our unit. It's a randomized controlled trial comparing a low dose of vasopressors. And when I say vasopressor, we mean norepinephrine. We're using 0.08 microgram per kg per minute of norepinephrine given as an infusion through a peripheral line 10 minutes prior to intubation, because it takes some time for it to act, and continued up to 5 minutes after tracheal intubation, and that's the time that we see the hypotension. And the other arm is using 500 ml of saline. So we've just completed this randomized control trial, 170 patients. Of course, it's a single center study, and at the moment we're doing the analysis and we'll have the results. And there's also a multi-center study from European Society of Intensive Care Medicine. I'm also part of this steering committee of the study, and that's called the prevention trial. And this study is looking at, on one arm, these patients who are undergoing tracheal intubation and critically ill are getting just the vasopressor, norepinephrine, and the other arm is a usual care. So I'm really looking forward to the results of these studies, because this will tell us whether there is a role for giving a low dose of vasopressor to prevent rather than just to treat the hypotension that occurs following tracheal intubation. So we're looking forward to the results of these.
No, that's great. So we'd be also eagerly looking to the findings of the study that you are already underway. So ma'am, quickly on the other aspect is you talked about the hemodynamics. Anything new for critically ill patients for preventing hypoxia and such patients?
Yeah,
Because the
so
complications
hemodynamics,
are
yes, but
quite
of course
catastrophic.
hypoxia, and it was good to see that the incidence of hypoxia is actually going down. And we're always worried about not getting the tube in, patient desaturating, not being able to reoxygenate them. And unlike normal patients with normal lungs, it's even if you preoxygenate these patients, their response to preoxygenation may not be so good as you see in normal healthy patients with healthy lungs. So the incidence, we've been cognizant about this, and we've become over time, I think, good at peri-intubation, oxygenation, reoxygenation. So the incidence was about 9%, and other studies have shown 9 to 12%, which is not too bad, not as high as the hypotension. But yes, we can do better. We can definitely do better. So I would say a big focus on peri-intubation oxygenation. Keep oxygenating. Whatever opportunity you have, oxygenate, the pre-oxygenation. And now we also give apneic oxygenation. So after, when you're doing a rapid sequence intubation, you give a muscle relaxant, you continue nasal oxygen during attempts at intubation. So you can prolong the safe apnea time. The pre-oxygenation gives you a certain amount of time, but you can prolong it using apneic oxygenation, using high-flow nasal oxygen. And pre-oxygenation, you can, recent studies have shown superiority of non-invasive ventilation and high-flow nasal oxygen, two therapies that we can use for pre-oxygenation, which gives you PEEP. So they are definitely superior to using conventional oxygen therapy, where we would use, bag valve mask, and we could use those for pre-oxygenation and continue them during attempts at intubation. And there's no, a study that's compared these two head-on. The Florali-2 study has not shown any difference between the two in terms of their primary endpoint, that was saturation going less than 80%. But in a subgroup of patients who had a PaO2, FiO2 less than 200, NIV was shown to be superior, probably because of more definitive delivery of PEEP. So these, and there are also studies looking at combinations, because these are very high risk patients. They're a very high risk of desaturation, patients with ARDS, patients with pneumonia. So, combination therapies have been looked at, combination of NIV and high flow. And I would expect even combination studies of, small studies are there of high flow nasal oxygen with conventional oxygen therapy. So probably this is the future. We have to look at better ways of peri-intubation, oxygenation, and reoxygenation. In addition to this, the experience of the operator also makes a difference, because we have to aim for first pass intubation success. So, the dictum is usually when you intubate a person, you should have at least two airway operators, and at least one should be an experienced operator, and various tools that can be used to improve first pass intubation success, like the use of videolaryngoscopes during the first attempt at intubation, and stylets and boozies not used as rescues, but during the first attempt at intubation have shown to improve first pass intubation success. So I think a combination of all these, if we get better at it and more trials demonstrating a benefit, will probably even improve our peri-intubation hypoxia that we're seeing as a complication.
Absolutely, very rightly said. Thank you, ma'am. So taking it forward, now in this era of technological advances, when we talk about the AI, when we talk about all about evidence is coming to play. Now there's an old name which is coming to play. That's Sherlock Holmes, the Sherlock Holmes principle and the Sherlock Holmes theory. So Dr. Praveen, would like to listen from you, because the principle of Sherlock Holmes methodology has been that it said that once you have discounted the impossible, then whatever remains, however improbable, must be the truth. So basically, yeah, that was the principle on which we have been harboring on about the Sherlock Holmes approach. Could you
yes.
throw some light as how does it stand here in today's critical care practice?
Okay. We all read about Sherlock Holmes when we were teenagers, and some have continued to adulthood. And the thing about it, of course, he's a fictional character created by Arthur Conan Doyle. But we all loved it. And what we loved about him is his two skills: the power of observation and the power of deduction. So about 2.5 decades back, when I was also very new in critical care, I thought, why can't we apply those simple principles at the bedside, the power of observation and deduction? And we didn't honestly have a lot of databases at that time. What it really means is, to give you an example, you know that if someone's sodium falls, the potassium should also fall, the chloride should also fall. So you start saying, okay, if the sodium falls, but the potassium doesn't fall, it goes up. What could it mean? Or with the same logic, if the sodium falls, normally the chloride will fall. You say, okay, but what if the chloride doesn't fall? And you start collecting these sort of odd situations. They're not the routine. They're the odd situations. And say, how can you narrow down the differential diagnosis? Okay, and you start collecting them. And it's not just biochemistry. It could be to ABGs. It could be we've applied it to X-rays, and you get a big collection of data. So what does it do? First, and to me the most important, though it's not really for everyone, it makes bedside critical care so exciting. You love just looking at electrolytes, urea creatinine, and saying, oh, I think this patient has an ACT secreting tumor. It impresses the residents, especially the young girls that are there, and it impresses the consultants who are, referring cases to you, etc. So, and it makes it exciting. You always want to pick up a pattern which the residents have missed. But in more practical terms, the fact that you can diagnose. I remember a case was in the casualty, a lady who was found unconscious in the mall, and she was brought in, and they referred to a neurologist, and he says, get a plain CT done by the time I come, and I'll be there in an hour's time. And one of my residents was passing by, and he looked at the biochemistry, looked at the lipid profile, said, this is myxedema coma. Don't waste time. Just treat it. And she got up. Imagine how impressive that is and how much cost saving it is. Because unfortunately, we have gone into a phase, maybe because of the medical legal pressures, where we don't really, how many don't use a stethoscope? Okay, they don't. It's if it's a neuro case, do you have the CT scan? Can I just see the film? Can I do this? Can I do that? Investigate. And that becomes expensive for the family. At least in India, the medical insurance cover is not that much. Imagine you could make a diagnosis just by routine tests which are done anyways. It saves also time. Instead of an hour that would have gone for that CT scan, you just took a few minutes to diagnose this. So that's what Sherlock Holmes' approach is. And I think it's very important to step back and look at a bigger picture. We always say, focus. And you'll see in my slides tomorrow when I present this, how important it is just step back and look at the bigger picture, because the clue is right there in front of you.
So having understood now what that approach is, where all can it be applied in critical care? That's one. And second is, how do we get to adapt this or learn this new principle that has been brought into practice now?
I see they're very good questions. It can be applied to anywhere where you have data. So it could be clinical data. I mean, so basic, it's not really data, but if you have hemiplegia and it's crossed or it's uncrossed, just that observation will give you deduction. All right. So you could apply it to clinical, you could apply it to X-ray. And I can tell you, for example, it's so easy on a plain X-ray chest, if you have a pneumonia, to pick up the organism. You know that there are alveoli, and the alveoli are interconnected by the pores of Kohn, Kohn. So if it's a very virulent organism like Streptococcus pneumonia, it secretes very watery fluid, and they would go through the pores, and therefore you'll have a continuous homogeneous patch. On the other extreme is mycobacterial infection, pneumonia, where it's caseous material, and therefore they won't go through the pores, so you'll have peripheral satellite lesions, acinar. So that is tuberculosis that's there. If you see pneumonia, it should really be liquid replacing the air. But in Klebsiella, there's too much liquid being produced compared to the air that is sucked in. So you get bulging of the fissures, increase in the volume. So all these observations are data, and you draw conclusions from it. So you can say, okay, this doesn't look like streptococcal pneumonia.
Yeah, thank you. Thank you, sir. I think the topic itself is going to be something new for most of the people. They wouldn't have heard of it, but we really need to get deeper into that and understand. So just the last point from you, evidence-based medicine, based on the data that you're talking about right now with this approach, how do we connect both?
I think what it does is Sherlock Holmes' approach narrows down your differential diagnosis. Okay, so you start getting into lesser possibilities and more focused investigations, etc. So that's it. There is no replacement for evidence-based medicine. It's not trying to tell you how to treat. It's more of a diagnostic value that is there. And then once you know that this is the problem, you can then specifically treat it and follow the evidence-based.
Thank you so much, Dr. Jan. I think we look forward to the lecture. And anyway, you've given a lot of insights, and we'll be surely more interested to hear about it.
Thank you.
So, Dr. Bram, I would now just go on with you. So, 2 decades, in fact, when we had the Provis trial, when we had the Dotrigan alpha coming into play, and then a lot of discussions happening, being withdrawn, and then going ahead with the same old plan as we used to. And now we have come with a concept of thrombo-modulation, which is again there for the last 1 decade, but a lot of emphasis coming around now. Would like to hear from you as to where do we stand today and how it's going to impact our day-to-day critical practice.
Thanks for the question, and so great to be a part of this panel. You know, it's interesting because I think the topic of the talk was thrombo-modulation, a new target in sepsis. And as you allude to, this isn't really a new target. There's a long history of targeting thrombo-immunomodulation in sepsis. And, you know, the pathways of thrombosis and inflammation are so inherently linked that we see this often, manifestations anywhere from small differences in our clotting cascade and PTT and INR right up to florid DIC and large-scale thrombosis in our septic patients. And so, you know, it makes sense to look at interventions that might target this pathway. And there is a long history using things like activated protein C and antithrombin. And although some initial promise, probably more around the range of negative trials in the last little bit. And so, you know, there's lots of excitement, I think, despite this negativity in the past for the future around thromboimmunomodulation. And I think it's probably twofold. One is that perhaps we have not properly accounted for heterogeneity in treatment effect in the last 20 years. And forget thromboimmunomodulation in a whole host of intensive care interventions. We have not focused enough on heterogeneity of treatment effect. And what I mean by that is that, you know, the totality of the evidence might suggest that activated protein C, for example, doesn't work. But it's quite possible there was a subset of the population that it did work for, and another subset of the population that it didn't work for, and that averages out to no treatment or even harm. And Pratik Sinha, who's in Washington, has actually published on this in the setting of activated protein C, where he was able to do latent class analysis, identify subphenotypes of sepsis, and actually show, based on the prowess shock and prowess data, that there was a subset, a subphenotype of sepsis patients that had better outcomes with activated protein C. It makes you think maybe we need to go back and redo so many of our trials if we're able to initially subphenotype patients and direct treatment based on it. The big challenge there is that subphenotyping and a lot of these biochemical markers take days to come back if we send them, which doesn't mean that it's very practical to analyze at baseline and then randomize based on it. But, with point of care testing and the ability to run these tests, in real time, things are changing. And we've seen that in ARDS, which I think when it comes to subphenotyping is probably 10, 15 years ahead of sepsis. But I think the future is bright around better investigating this heterogeneity of treatment effect. And I think it will have massive implications when it comes to modulating thromboinflammation. I guess beyond that, the other thing is new targets.
Yep.
And folks have, looking at new targets like poly-P and antiplatelet agents, specifically GP3A2B inhibitors, extracellular vesicles, these entities that are so integral for cell-to-cell communication, and now recognizing that they're prothrombotic perhaps, or at least a subset of them that might trigger the extrinsic pathway. And there's a lot of work looking at targeting these pathways with new biologics. A great potential success story is factor 11-12 inhibitors that have shown efficacy post-knee arthroplasty, although folks have not investigated their efficacy in sepsis patients. So I think there is a lot of excitement to come, but challenges that we've faced in the last little while.
Yeah, thank you. So we have a lot of research done over it, no doubt about it. So coming on to the practical application. So how do you foresee it? When and how? How much will it be benefiting the clinicians at the bedside? Or is it going to be something that we have a knowledge and information about it, but we're not able to apply it?
Yeah, I mean, that hits home your comments, especially around this exploration of subphenotypes and the idea that there might be subpopulations of patients that might respond to some of these interventions differently than others. And, I think that this is the eternal struggle, is that up until now, a lot of the work has looked at characterizing these patients post hoc, once the trials have already been done. But a great example, again, to borrow from the ARDS literature, would be Danny McCauley's Panther trial, which is actually, they've been able to work with industry to develop a point of care testing that's able to subphenotype patients in real time at the time of presentation. The idea being is that you might be able to differentiate treatment up front, and they're running a randomized control trial. And I think that this is not that far away in sepsis, that we might be able to subphenotype patients when they come in the door, find those that are maybe more pro-thrombotic or pro-inflammatory, identify the specific cascades that are dysregulated, and initiate targeted therapy looking after those. And that might be pathogen specific, it might be host specific, but coming from an evidence-based medicine guy, I think the future is personalized medicine with an EBM spin for sure. And at the rate of the way things have been changing in the last little while, I don't think we're talking about tens of 20s of years in the future. I think we're talking 5-10 years in the future.
Great, thank you. So we look forward to that. Quickly, if you could just highlight on your other topic that you have been covering here, that's the preventive post-extubation invasive ventilation for high-risk ICU patients. Briefly, you can just highlight it.
So many of our patients, that it's such a difficult balance in extubating patients. You don't want to leave folks intubated for too long. We know that's bad. You don't want to extubate folks too soon, because then you run into respiratory failure. They require reintubation, and that's bad. And so I think anything that we can do to mitigate post-extubation respiratory failure, the better. And so we've examined tools like high-flow nasal cannula and bilevel ventilation to help prevent reintubation. And the bottom line is, from reviews of the literature that we've done and clinical practice guidelines that we've done, is that both are beneficial. And probably we're underusing high-flow nasal cannula post-extubation. The data we have suggests that using high flow reduces the need for reintubation by 50%, and that's across risk groups. So when I'm extubating my patients in the ICU, I really think in my brain, what is their risk of reintubation? And even if I find a patient that I think the risk of reintubation is 5%, using an intervention like high flow that's able to reduce that by 50%, that's a number needed to treat a 40. For every 40 patients that I extubate and put on high flow, I'm reducing one reintubation. And, I think I can make an argument to those that are holding the funding envelopes that there's a compelling argument to use an intervention like high flow that probably costs $50 or $60 to prevent a very costly reintubation.
I think that's great. Thank you for your concept. So before we end, one message from each of you. So I would like to give to the audience regarding your subject or anything that goes as a take-home message from you.
Yeah, as much as we recognize there are limitations to the way in which we've been looking at acute kidney injury, as you suggested, the inclusion of things like biomarkers is not such a simplistic kind of a process. I think it does complicate it a lot more, not just in terms of the cost, but in terms of our lack of understanding of the interactions that these biomarkers have. And ultimately, I think there too, we probably will migrate to something like a phenotypic, subphenotype identification of these patients, which may become still a non-feasible kind of technology. I'm a little skeptical about how quickly a poor country like us can adapt something like this.
Yeah. I think we need to think beyond anatomical difficulty, and I've just talked quite a lot about the physiological difficulty airway, but we should be aware of this entity and we should do everything possible to optimize the physiological range, whatever is possible before intubating these patients and try to mitigate this risk of complications that is there in this condition. Yeah.
Very crispy. Dr. Jain.
I think everyone who's entering critical care as a specialty should get introduced to the Sherlock Holmes approach because it spices up the bedside rounds. And I hope they enjoy it as much as I do. I just love bedside critical care.
Great. Dr. Bram, the final comments.
I think a lot of our trials in sepsis in the past have been limited based on our syndromic definitions that we use in the ICU. And instead, looking at treatable traits and evidence-based precision medicine is likely the future.
Great. Thank you so much. So I'm Dr. Asif Ahmed. I'm the head of critical care medicine at Tata Mean Hospital, Jamshedpur. And it has been a privilege to be hosting all the panelists, the esteemed ones here. And we'd like to thank the Indian Society of Critical Care Medicine and Criticare 2025. Best wishes and good day to all. Thank you so much.
Thank you.
Thank you. We are on time. Thank you so much. Really noted and good. Thank you so much. Very nice.